Hi, my name is Allison Symes. I am a family nurse practitioner, and I have a patient being referred to the West Hartford Hospital ER for suspicion of diabetic ketoacidosis. Helena Mercado is a 66-year-old Hispanic female who is one of my primary care patients. She was brought in this morning to the community wellness clinic by her husband for one night of abdominal pain, nausea, and vomiting. In November of 2025, Ms. Mercado was experiencing uncontrolled blood sugars while taking metformin and was recommended to add Lantus once nightly at 8 units subcutaneously. Patient reports taking metformin regularly, but missing about a week of her Lantus because she got tired of sticking herself with needles. Prior medical history includes diabetes mellitus type 2, diagnosed May of 2025, gastroesophageal reflux, hypertension, and obesity. Patient reports no recent illnesses, stressors, or injuries that occurred prior to the onset of symptoms. I suspect she could have diabetic ketoacidosis brought on by discontinuation of insulin supplementation. Patient presents with moderate nausea and abdominal cramping, which she rated as a 7 out of 10 pain. Vomited twice at home prior to arrival. No hematemesis was observed. Patient is anxious, short of breath, reports sudden onset of excessive thirst since last night with urinary frequency. Upon examination, her fingerstick blood glucose was 877 milligrams per deciliter. Urine dipstick revealed large amounts of ketones, glucose, and protein in her urine with a pH of 5.7. Patient has a fruity smelling breath, dry mucous membranes, is alert and oriented to person, place, and time. Her respiratory rate is 36 breaths per minute. Oxygen is 94% on room air. Heart rate is 117 beats per minute. Blood pressure is 97/58. Differential diagnoses may include diabetic ketoacidosis, hyperosmolar hyperglycemic state, alcoholic ketoacidosis, starvation ketosis, hyperemesis of pregnancy versus anion gap acidosis. Diabetic ketoacidosis is the assumed diagnosis due to a hyperglycemic state, presence of ketonuria, fruity smelling breath, nausea, vomiting, polyuria, and polydipsia. No in-clinic treatments or medications were given. At this time, the patient is hyperglycemic, hypoglycosteric, albuminuric, ketonuric, has low urine pH, is tachycardic, tachypnic, hypotensive, anxious, and alert. I recommend at this time that Ms. Mercado be transferred as soon as possible to the emergency room for further testing, evaluation, and management to bring her blood sugar down and stabilize vital signs. Thank you.